Hi, I'm Stephanie Oliver, and this is my ILS Cardioversion OSCE.
Cool, so you've been dispatched to a 70-year-old male. He's got chest pain and collapse. He had the acute onset of chest pain, unable to stand due to near syncope and dizziness. He has a previous MI 5 years ago, chest pain that is current and feels different. He's pale, clammy, eyes open to voice but unable to obey commands. Patient is seated on his lazy boy recliner. He feels palpitations going into his neck and his heart is going to jump out.
Okay, so I would start by assessing scene safety, make sure everything's safe, getting the patient, checking the ABCs, and start with some vital signs, which I already have. And then I would be looking at laying him down and having a look at his vital signs, or at his rhythm strip, because his blood pressure is quite low. He's severely hypotensive and not obeying commands, so that would be severe cardiac compromise. So I would be then calling for backup, so I'd R50 for backup, and I would be putting some oxygen on, high flow oxygen with reservoir mask. And I would be looking at the rhythm, and so it's VT. And so I would be attaching the defib pads. And possibly printing off a rhythm strip. If there's time to get a 12 lead as well before we consider anything else. So we're confirming that, yes, he is in VT. I'm going to prepare the resus equipment right next to the oxygen. And I'm going to put IVs in, so at least one large bore IV, so 18 gauge or under. And then I would be thinking any other differential diagnosis for VT, which would be anything, could be electrolyte imbalance, making sure it's not SVT with aberrancy. If you're not sure, then we should treat for VT and cardiovert. So I've got a little rhythm strip, printed out a little bit. Everything's attached. And now I'm going to consider analgesia, but he is not obeying commands, so he does not need any. If he was needing analgesia, we can give 0.5 milligrams per kilogram of ketamine if needed. And then I will go to check my checklist. So pads are on, apex and sternum, anterior posterior positioning. Got the defibrillator on and in manual mode. We select the energy joules, max energy. We're going to select a lead with an R wave, so we're going to go ahead and select lead 2. That has the best visible view for us. We're going to synchronize. Stop it from printing and speaking to us. So we're going to confirm there's a detection signal above every R wave, which we can have a look at on the print off, and yes, there is that. Okay, and we're on max joules, and we're going to go ahead and do our shot. So we're going to charge and make sure everyone's clear before we do anything. Yep, everyone's clear. Shocking now, and we're going to push and hold until the shock is delivered. Okay, so now we're going to reassess him, check his ABCs again, have a look at the monitor, assess the rhythm, and if he's still in VT, which on the monitor he is, we can do one more shock, and so we can do that again. So go through and sync, do a print off, and make sure we've got the markers above every R wave, which we do. On there, and we can charge again, and it's charged and shocking now, all clear, push and hold. And if it's not reverted after a second time, then we transport to hospital. We'd reassess after the second time, obviously, and keep checking on him. And I never talked about it, but I'll say it now. The severe compromise for this patient is the inability to obey commands and the extreme changes in vital signs, mainly being the hypotension, and can be high risk of cardiac arrest. So he has a history of cardiac problems as well, and they look status 1. I think that's it. Thanks.